All right, great. Good evening, everyone. First of all, thanks Meredith and the Singapore Physiotherapy Association for inviting me to share my humble experience in managing patients with COVID-19 in the ICU, and also to provide an opportunity for all of us to learn from each other during this unprecedented time. So I'm going to talk about the experience that we had in our institution managing patients with COVID-19, and also using one of our ex-patients as an example. So the patient is a 58-year-old female who traveled overseas for a holiday, and she presented onto the emergency department on the 26th of March with cough and dyspnea. She was also noted to be confused and lethargic in the emergency department. Her only past medical history is scoliosis, of which she underwent a spinal instrumentation when she was 12 years old. And the X-ray on the left side is hers. So you can see the spinal instrumentation in situ, as well as her poor lung compliance. She was subsequently diagnosed to be positive for COVID-19. Functionally, the patient is ADL independent, community ambulant without aid, and lives with her family and used to work as an accountant, but she's now currently retired. Her hobbies include playing Sudoku as well as sewing. This provides a snapshot of how the patient's journey in the ICU is like. She was admitted to the ICU on the 26th of March in another institution. And since then, she was mechanically ventilated, she was paralyzed and prone. On the 30th of March, she went over to, on the 30th of March, she was transferred over to NUH for ECMO. 31st of March. And she was on the ECMO for about 30 days. During her hospital stay, she also acquired acute kidney injury, which requires her to have dialysis. Other things that are relevant to her is also she underwent a tracheostomy on the 23rd of April and had 5 episodes of bronchoalveolar lavage because she had recurrent episodes of pulmonary hemorrhage. Unfortunately, during her stay in the ICU, she spent like 102 days in ICU. She was subsequently discharged into the general ward, but unfortunately she was readmitted because she had type 2 respiratory failure because of pneumonia. After that, she was discharged to the general ward again. So as she was first admitted to the ICU, she was intubated, she was sedated, on dialysis, ECMOs, and attached to numerous lines and wires, which are all designed to save her life. But at the same time, she also lost her ability to communicate with the surrounding environment and to interact with people. And she was also dependent on the nurses for virtually all of her ADLs. The first priority when she was first admitted, obviously, was to save her life. But the second priority is also to ensure that if she survives this hospital stay, to ensure that she has a fairly decent quality of life. Unfortunately, a significant number of critical care survivors just do not manage to return to their pre-morbid level of function, even months and years after their discharge. And this is termed the post-intensive care syndrome. It describes the mental health issues, cognitive impairment, as well as physical impairment that the patients face even after hospital discharge. So if we were to translate it functionally, this group of patients may not be able to return to work, or they are forced to return to a level of work that pays less than how it was first paid. The mental health components such as depression and anxiety can also extend to the family, and overall it results in a decrease in quality of life. Experts have recommended the use of the ABCDEF bundle to mitigate the effects of PICS. So it comprises of A, awakening, meaning the use of light or minimal sedation, having spontaneous breathing trials, coordination of care and communication among various disciplines, delivery monitoring, and of relevance to us physios, early mobility, and F for family engagement. It is important to note that this intervention is only useful or best done when it is done in a bundle form. So for example, it is going to be very difficult to mobilize a patient early if the team still hasn't minimized the sedation. There are various studies that shows the safety and feasibility of early mobilization in the ICU. There are also several algorithms and guidelines available to guide the clinician on when to mobilize the patient or when it is safe to mobilize the patient. This is a landmark kind of workflow by Stiller et al. In 2009, where the clinician can see or determine whether the patient has enough cardiovascular reserve, respiratory reserve, or any other contraindications to mobilization. We also have the traffic light system by Carol Hodgson in 2014, as well as the paper by Morris et al. In 2018 to see what kind of exercises we can do at various stages of the patient's recovery in the ICU. So the same guiding principles can be transpolated to patients with COVID-19. So similar to how the Singapore government is managing COVID-19 in Singapore, rehab can also be done in stages in this group of patients. So phase 1, the barriers that we have to early mobilization will be the presence of ECMO, dialysis, the patient was sedated, and unable to obey commands. So the aim of physio and the medical team is to prevention of muscle contraction, prevention of joint stiffness, and pressure ulcers. And what we started on was some active and passive range of motion exercises, calf stretches, regular turning by nurses, and when the patient is more alert and able to obey commands, the use of resistive bands just to build up on her muscle strength. Phase 2 was started when the patient is hemodynamically stable and alert, and this is when we started to do more out-of-bed activity. This is with the aim of promoting lung expansion, encouraging use of postural muscles, and to facilitate weight bearing. Again, we continue on with our range of motion exercises, use of resistive bands, but we also started on standing, marching on the spot, mini squats, heel raises, some engagement in EDLs, as well as restricted ambulation. I think a point to note about this particular patient is that in phase 2, we were actually quite cautious, especially when the medical team was trying to cycle the patient between the ventilator and the BiPAP, and from the BiPAP subsequently to the track mask. It was noted that this patient tends to get tachycardic on exertion, and she also tends to get short of breath and tends to desaturate on exertion. So in this phase, rehab was always done at a oxygen support level that is higher. In phase 3, the aim is to return the patient to her premorbid status, improve exercise tolerance, and to improve muscle strength. And we go about achieving this goal by facilitating independence in ADLs, strengthening exercises, higher level balance training, and assisted ambulation. So by ICU discharge, patient was already able to ambulate at least 30 meters with minimal assist. So honestly, the intervention in the ICU is not that much different from a typical long-stayer patient in the ICU. So what's different this time in a patient with COVID-19? So first and foremost, the critical aspect of rehabilitation that we have to take note is infection control, with the aim of having staff safety and prevention of cross-contamination. And the measures we took are as follows. Firstly, the use of 5-part PPE with our Buffon cap, mask, gloves, our visors, and our long gown. In the early stages of the disease, it was a race against time to train as many therapists as possible on the use of PPE and PAPR to make sure that they know how to don it on and doff it off properly. We also had regular infection control audits and had to come up with a standard operating protocol for allied health professionals just to ensure that there's some consistency in how we go about managing patients with COVID-19 and how to logistically integrate them into our workflow. We also segregated our staff into pandemic teams and business as usual teams so as not to have or to reduce the amount of cross-contamination. A separate set of scrubs are also provided to the pandemic teams, which can then be laundered internally in the hospital. Shower facilities are provided in the pandemic wards, and there is mandatory reporting of temperature twice daily. There's also segregated lunch timing between teams, and similarly to this presentation, in-service presentations and group discussions were all done virtually. The second aspect is the use of rehab equipment, and we just need to make sure that all rehab equipments are thoroughly disinfected. So we disinfected all rehab equipments after every patient use, and to only use patient use equipment. So for example, the use of resistive bands instead of weights just to build up on muscle strength. Chairs are kept strictly in the patient's room and not shared, and rehab is done strictly in the
Oh,
patient.
and Becca want to come tomorrow, can or not?
The other critical aspect of rehabilitation is to identify critically ill patients that are fit for rehab early so that patients get timely value-added rehab services. So in our institution, the ward, our medical ICU, it is a blanket referral ward to the physios. So there is active screening by the physios to determine whether or not the patient is fit to be seen. Particularly for this group of patients, it is very important to weigh the risk to benefit ratio of rehabilitation. So as mentioned by Meredith, we do see a good number of dormitory workers coming into to the hospital, and these patients are normally fit, healthy, and strong. So early mobilization will not benefit them so much, especially if they're in the ICU for just a couple of days. It is also important to have open discussion with the your medical and nursing colleagues, because in the early stages of COVID-19, it was quite unclear how the trajectory of COVID-19 patients are and how they react to exertion. It's also important to note that in our institution, the nurses are trained to mobilize critically ill patients without the physio, so they can sit the patient out onto a chair. So if they report that the patient is already breathless or mild exertion, such as turning or sitting on a chair, then the physio will not need to go into the patient to see the patient at that point in time, when all they can tolerate is just sitting out on the chair, for example. Always attend mild exercises first, and to always provide patients with additional oxygen support. The other aspect is to identify potential musculoskeletal problems and to make sure that we identify them early. So there needs to be robust MSK assessment. So for our particular patient, after some time on the ECMO, for some reason, she developed a decreased range of motion of the shoulder. So we tackled that early and gave her some exercises as well as range of motion exercises to do. Last of all is to identify psychological and cognitive issues early. So in our institution, the nurses will do chem ICU at every shift just to detect any delirium, frequent orientation, and to educate the patient on what post-intensive care syndrome is about. Some of them needs a lot of reassurance because they still have nightmares or trouble sleeping and some hallucinations. But it's also our role to educate them that this is a symptom that some of other critical care patients also face. It's also prudent to have appropriate referral to the occupational therapist for cognitive training and to facilitate communication between the patients and their loved ones virtually. So this journey ends on a happy note. The patient was decannulated while she was in the hospital and was discharged on the 28th of July. Functionally, she's able to ambulate independently without aid and able to perform ADLs independently. She's also eating and communicating well and does not require dialysis. I've now come to the end of my presentation. Thank you so much for listening.